Assalamu alaikum. Starting with the clinical cases, we have Mr. Jones, 65 years, with complaint of abnormal movements and misbehaving. Sit with Mr. Ronald, his son. You will have to take history and to address the concerns.
Hello.
Okay, just a second to share the timer.
Okay.
Yeah, here you go.
Hello.
Yes.
I'm Dr. Azhar, one of the junior doctor. And are you Mr. Ronald, son of Mr. John, 65 years old?
Yes, I am.
Okay. Today I'm here to discuss some health issues regarding your father, and I was also take address your concerns. Your father concern. Is that okay with you?
Yeah, sure.
Okay, Mr. Ronald, can you tell me about the problem of your father? I have came to know that he is having abnormal movements. Can you tell me in detail?
Yeah, actually, my father, um, he's for a long time not feeling well. But recently, I noticed that he's having some abnormal movements, which is new for him. Yeah, that's why I brought him to the hospital.
I'm sorry to hear this. We will try to solve the problem. Can you tell me for how long he is having these abnormal movements?
Yeah, almost now 3 weeks.
And before 3 weeks, he was totally normal.
No, doctor, my father having a lot of disease and he's not well.
Can you tell me what diseases he is having?
Yeah, he had diabetes and hypertension, change in the fat profile, and he had heart attack and he had stroke. He's not that much active, and yes.
Okay. And he's having all these problems, diabetes, hypertension. You told me for how long? Can you tell me?
Yeah, for a long time, doctor, maybe 20 years now.
20 years.
Yes, or more than this.
These are well controlled or not?
Actually, he wasn't, doctor, until he had this stroke 1 year back. And after that, we tried to control the diabetes because his GP start him on what's called insulin.
So at the time, 1 year before you came to know that your father is having diabetes, you want to say
Yeah,
like that?
he was having diabetes, yes, but I mean after the stroke, he had the diabetes being more controlled.
And what about the hypertension?
Yeah, almost controlled, 140 over 90 for the last reading.
And can you tell me more about abnormal movements as you told from last 3 weeks he is having abnormal movements. Uh,
Yes,
can can you tell me more about the before 3 weeks he was totally normal?
yes, but he had stroke and he had left side weakness. But recently he was on some physiotherapy and it's not moving that much. But nowadays I noticed some change in the movement being abnormal and on purpose. And I cannot control it. Always he is having this movement.
These movements are purposeless, not purposeful.
Yeah, no purpose for it. Yeah, like purposeless movement. Yes.
So since 3 weeks it is increasing, decreasing,
Yeah,
or same.
it's I notice it's increasing, doctor.
It started suddenly or gradually.
Gradually.
Okay, can you explain me something about the movements? Something, what type of the abnormal movements? Can you explain me a little bit?
Yes, it's like a wavy movement of the arms and the legs. You can, yeah, describe like this. It's like wavy or like Yeah, like a snake-like movement, like this. His arms moving like the snake.
It is present all the time. I mean to say, at
Yeah,
the time of during the
e-
sleep and
even
day
yes, day
is
and night.
during the sleep he is also
Yes,
having this
still
problem.
yes.
Is have you noticed anything that increases this problem?
Uh, it's maybe when he's less asleep, it's happened.
It happen. And anything which improves this?
Um, no, doctor, I didn't notice something can improve. Even with the movement, it's there. It's not disappearing.
Mr. John, he is also having some problem with his memory.
Yeah, you're right, doctor. He's forgetting the things nowadays.
Forgetting the things. And can he concentrate what is going on?
No, no. I notice he's not anymore focusing with us and almost his bed bound, doctor.
Can he follow any instructions which we give?
No, it's very late and the response, I mean, very late and sometimes he's not responding.
Is he aware what is going on in the surrounding?
No, I don't think doctor is he's aware that much. But sometimes he's awake and some other time he's not.
And he's not aware of what is happening in his surrounding.
No.
Okay. Beside these, as you told me, these multiple comorbidities
Mm-hmm.
like diabetes, hypertension, he's have
Mm-hmm.
stroke and dyslipidemia.
Yes.
He's having anything else in?
Yeah, he was having before hepatitis B and he took some medication.
And what about now, madam? It is controlled or not, hepatitis B?
We didn't follow doctor, but I think we didn't feel something changed according to his GP, maybe controlled.
And what I want to see is the medication list.
Yes, you can see aspirin and insulin and atorvastatin and phenytoin and sometimes he's taking quetiapine.
Utropine, and
Yes,
insulin also told you.
insulin.
Okay,
Yes.
okay. Uh, any over the counter he's taking any medicine,
No, doctor, he is not.
any herbal medicine?
No,
I'm sorry to ask you, he's taking any party medicine?
no, doctor. He's not active and communicating that much.
Eh, any family history which I want to, which I should know?
Yeah, I guess my grandfather died with something in his brain, but I don't know what exactly.
Died at what age?
Uh, at age of 60s.
60s. And rest of the family normal.
Yes, so far, yes.
Okay. Any stresses in his life?
No, I don't think he has any stress. He is always at the bed. Yeah, I feel sometimes he's like low mood because of bed bound.
Any what about his sleep?
I
Is
can't feel he's sleeping well, doctor. He's all the time in the bed, and sometimes he's sleeping in the night, sometimes the day. No specific time.
uh, is he having raised body temperature?
No,
Any change in weight?
no,
Any changes in appetite?
no.
Any sweating?
Sweating? No,
Any lumps and bumps?
no,
Any joint problem?
no,
Uh, I'm sorry to ask you if he's taking any recreational drugs.
no, doctor.
No, he's a smoker.
He was, but now he's not able even to smoke.
Okay, what about alcohol?
Actually, I try to remove this alcohol because whenever he's holding the cup, it falls from her and drop from his hand.
Okay, but he is taking this alcohol or not?
Yes, I removed it recently because I'm afraid he hurt himself.
Before he was taking
Yeah, he was drinking, doctor.
in the safe limit,
I guess it was, yes, socially and with the same with the limit, yes.
and definitely he is not driving at this time.
No, no, at all.
And any job he is doing at this time or
No,
no?
doctor, no. Since he had a stroke, he is at home, retired now.
He's having a long-term partner,
Yeah, my mother with us, but at
any
home.
casual part, any
No,
casual
I
partner.
don't. No, doctor, I don't think.
Okay. Any headache,
No,
any visual problem,
no, he didn't say.
any hearing problem,
No.
any speech problem,
Yeah, I guess he's not talking like before.
any weakness in the limbs
Yeah, there is weakness in the after the stroke in the left side.
after the stroke, any numbness,
No,
no. Uh, any problem with his walking? Can he walk normally?
no, doctor, it's difficult to move as at the stroke and the weakness in his legs. He's
He
not
cannot walk.
walking. Yeah, he's unable.
When he's walking, his arms are swinging or not?
He needs support and he always needs support to walk, but he can do with support.
Can do sport. Okay, can I examine him?
Yes.
Okay. I
Yeah,
will
you can.
start.
Yeah, how what you want to start with?
I want to start with the hands.
Yeah, there is deformity in the left side, contracture,
Mhm.
and in the right arm, you can notice the abnormal movements. It's like piano playing or uh, some abnormal movement, involuntary movement.
Involuntary movement. Any bradykinesia,
Yeah, there is, and
okay,
hypertonia as well. Yes,
hypotonia. Any rigidity also at the wrist and the elbow,
no rigidity, but little hypertonic.
little hypotonic. Okay, I want to check the pulse.
Yeah, it's 70 regular,
Mhm. Okay, and what about the blood pressure?
normal blood pressure 140 over 90.
Any postural drop?
No,
Okay, I want to check some cranial nerves, especially seventh cranial nerve.
nothing.
Nothing. Any neck stiffness?
No neck stiffness.
Okay, I want to do check his heart
Heart, nothing important. S1, S2, no murmur.
and okay, and then I want to check his gait.
Yeah, he's unable to walk, so skip it.
Okay, and what about the Romberg test?
He can't stand. He's on the bed.
Okay, Mr.
2
Naronar,
minutes left. Yeah.
what is your concern?
Yeah. What's my father having, doctor? Is it something serious?
Uh, I appreciate your concern. After taking your history and examination of your father, I came to know that he is having a condition which we call in our languages Huntington disease. Don't bother about these medical terms. This is a disease in which there is some problem in his brain, and due to this problem, he is having abnormal movements, as your father is having. And there may be some precipitating factors like he's having multiple comorbidities like diabetes, hypertension, dyslipidemia, and he's having heart attack and stroke. So on the basis of these, he's having. I came to know that I'm suspecting that he's having a condition called Huntington disease.
So what he will do for my father, doctor?
Okay, okay. I will make multidisciplinary teams, and I will run some tests to exclude other diseases. and then when I will be having the results, I will be discussing with you the results of your father. Is that okay with you?
Yeah, doctor. Okay. Any possibility, doctor, to have this disease? I'm talking about myself, doctor.
Yes, there is a 50% chances that you can have this problem.
Okay, doctor. Will
But
you do screening for my?
what is your age?
I am 40s,
You have
41.
any problem?
No, no, doctor. But I'm worried, doctor.
Okay, I appreciate your concerns. If you don't have any problem, we usually do not recommend because there is no treatment for this, and you just will be in depression and tension,
Excellent.
and you may
Okay.
lose your in the future insurance. It will not help you.
Okay.
You
The
have to
time
have.
is up. Perfect, Doctor Azhar. I will start examiner question. Please present your case and give me differential.
Okay, today I have Mr. John, 65 years old. He's having abnormal movements from the last 3 weeks. And he's also having multiple comorbidities like diabetes, hypertension, dyslipidemia. And 1 year before, he is having heart attack and he's stroke also.
Yes.
Stroke. And he's having abnormal movements with abnormal, it's just like he's playing piano, and there is also bradykinesia, there is a rigidity also, and hypertonia, and his behavior is abnormal, and he's having some problem with his speech. He cannot walk properly, and he's not taking care of himself, and he's also having memory problem. On the basis of these, if I collect, he's having a condition we call Huntington disease.
Okay. What other differential for this case?
Uh, I can also consider Parkinson plus syndrome, like multi-system atrophy, and I could not find any postal drop, supranuclear palsy, but I could not find any problem with his vision, and I there may be also neuroacanthocytosis, maybe at the bottom I can put
Okay. You told me this is Huntington. So what this movement called?
chorea.
Yeah. So again, now can you give me differential for the Korea?
Differentials for the chorea. Uh,
Possibly
I
in this
think
patient. What might be a reason for this movement?
this uh, I don't think that there is any specific reason. We do not know the exact cause why this patient, why the abnormal movements in these patients are there. It may be genetic. It may be genetic anticipation. Anticipation means there is a aggressive. It is transferred to the next generation in aggressive and successive manner, and it appears in next generation with more aggressive disease.
Mm-hmm. Okay. So you told me, or I will ask you more. What do you think other cause of Korea, not in this patient? What do you know?
Chorea gravidarum, but it is
Okay,
uh, neuroacanthocytosis, SLE,
excellent.
and multiple sclerosis, but sclerosis usually in the females and young age, 20 to 40 years, he is 65
Okay,
years.
one
Rest of the
more.
I do not.
What do you think about drug induce
Yes, yes, he's he is taking Qtipin, maybe.
antipsychotic and anti-epileptic? He's on phenytoin. Okay, this is in this patient.
Yeah.
What about Wilson? Is it one of the causes of Korea?
Wilson, maybe.
Yeah,
Wilson, maybe.
but not in this case. Okay, let's go to the investigation. How you investigate this patient?
Actually, there is no specific test to diagnose this. We
Mm-hmm.
will do some investigation to rule out other causes, like we will do the CBC to rule out other conditions, and we can go CT MRI, especially in the CT MRI, we will check the bicordate diameter, this is a reliable marker of Huntington disease.
What's
And to confirm the disease, we will do the genetic testing.
yeah, okay. You told me about anticipation, right?
Yes.
Do you know the name of the gene?
Uh, Genes are, sorry, I forget.
CAG, right?
Yes, CAG,
Yeah.
CAG, CAG.
Okay. Tell me how to manage this patient briefly.
There is no specific treatment, but something can be done to control his daily to control his uh, this abnormal movements. Likewise, benzodiazepines for chorea can be given, and then if patient is then for other we can give tetrabenzoin. Tetrabenzoin can also be tried, and if the patient is having bradycardia, rigidity, then levodopa or dopamine agonist, they can also be tried. And since this patient is having low mood, we can also give SSRI.
Okay, so you are giving pharmacological therapy, but still the
No,
most
we will
important,
make the
yeah,
multidisciplinary team. We
yes,
will
always
make the
start.
multidisciplinary team,
Yes.
and under the multidisciplinary teams, we will have the physiotherapists, occupational therapists, neurologists, and specialist nurse, and we
Mm-hmm.
will give non-pharmacological therapy. We will advise the patient do not drink alcohol, avoid drinking alcohol because this may be a triggers, and then for pharmacological therapy, as I have told you, we can give. And most important is that these patients they are at risk of death, like pneumonia, heart failure, and suicidal. So they should not be left alone, and
Excellent.
uh, and there should be
Yes.
some proper care and one person always sitting with him. And if you need any
Perfect.
help, we
Yes.
can take the help from the occupational therapist.
Excellent. Okay. If this patient having pneumonia, what you suspect the cause of pneumonia?
There may be aspiration pneumonia.
Yeah. So what team concerned?
Team,
Yes, for
alt,
this
alt, alt.
SOL team. Yes. Speech and language therapist. Yes.
Yes,
Okay. Perfect. I have no more question.
thank you very much.
Well done, Dr. Azhar. It's a difficult case and difficult scenario. I make it more complicated just to try to pick up the most important finding and to correlate with the diagnosis. So you can here put, as you said, Huntington in the top by the description of the movement, and you can put also the drug induced he's on anti-epileptic medication and antipsychotic. This is the second differential. I will ask you if this patient with a stroke, okay, he has a stroke or he had history of stroke, and he had unilateral movement. What you suspect? What's
You mean
called?
Parkinson?
Sorry?
Parkinson?
No, no, unilateral. No, not tremors. Same movement.
Same movement with stroke.
Yes, stroke with same unilateral movement, dance-like movement.
Hemibilismus?
Yes, hemipalismus. And what the cause of this? Stroke in
Uh,
which?
there is a problem with the cardiac nucleus, I think.
Not caudate nucleus.
Uh,
Subthalamic. Yes, subthalamic.
Subthalamic hemibilismus.
History of stroke, you can put it as differential, by the way.
Okay.
Yes. Okay, back to the complaint and the history. I guess you covered most of the important finding here. The patient is complicated and he had a lot of comorbidity, so you have to control all this and to ask about all the risk factor. Uh, the liver here also you can think about Wilson, and you have to do examination of the liver when you do examination. but I put it on also to be in mind and to distract or to put it in the differential as chronic liver disease. Still, it's one of these differential along with the Wilson if the family history positive for Wilson. But you
You
can,
gave me also is having hepatitis B also. So
yeah,
could be.
that's why, yeah, you can put hepatitis or chronic liver disease. But it's controlled just to put it in your mind. Don't miss any positive finding. Sometimes they are bringing scenarios like this, huge and a lot of information and data. So we have to take care about these positive findings. Again, the description of the movement, you have to ask, how is it? As I said, purposeless and it's not voluntary. He can do anytime. It's not relieved, and even sometimes with sleep. Uh, this is for the analysis of the complaint. The other CNS system you have to, which is the relevant system, you have to ask all the question you ask already: the headache, the vision, the hearing, the balance, weakness, and it's there because of a stroke and pins and needles. It's very important. The swallowing difficulty, also one of the positive or possible finding. The cognitive function, the memory, the sleep, as usual, and the stress, SMS, as you are doing usually. So you have to ask all these questions as relevant system. The other systems related to the past medical history, as you ask quickly, what medication is he controlled, is he compliant, and who's taking care of these things. Then the other system review quick, like chest pain, any change in the bowel habit, you didn't do it.
Yeah,
Try
yeah,
to
yes.
touch it by one
Yes,
question, yeah.
I
And
forgot.
no problem, but some question you have to remove it, like any casual relationship. I don't have any, or also,
Yes,
yeah, you don't suspect this person will have. He is bed bound,
yes,
so
yes.
yeah. Alcohol also, yes, you can ask about alcohol, but if he said he's not taking alcohol, so try to skip these small things and to ask about others. Smoking and the job, yes, you ask. And any patient, elderly, frail like this, you
See
have
you.
to
See
ask
you.
about, sorry, you have to ask about the support at home. Who's taking care of him? Who's helping him? I was the one volunteer saying he is yes walking with the stick, but still you have to offer it. Does he need any support at home? Who is taking care of him? These things the examiner like, and also the swallowing, the eating. You ask for the appetite, yes, but you can ask,
Following.
yeah, how, yes, how is his swallowing? Is he okay? He can eat alone, or does he needs any aid for the swallowing like that? Okay. The family history is very important here. Yes, he's had family history of Huntington. So I will not say he was diagnosed with Huntington, the father, I mean, but he has issue in his brain. So it was Huntington. And if you ask more, I will tell you, yes, it was the same memory, and he wasn't, his behavior at the end was not okay, and so on. This is for the family. I guess the other in the examination, yes, you examine most of the things as CNS, tone, power, reflex. Always do it in this step manner. I mean, tone, power, reflex, and coordination, and the last, the gait. However, I told you no gait in this patient, he's unable to walk. So you can do the others examination and sensory, for example, one sensation for the deep and one for the superficial, if you have time, of course. Pronator drift also
In both
important.
limbs, upper and lower, yeah, upper limb.
Yes, do it in upper or lower, either here or there, but
Oh,
not both, and don't miss all. So at least one of them, and do it in comparison. I mean the upper together or the lower together. Okay. In this patient, you'll have pronator drift positive for the stroke in the left side, and the involuntary movement in the other side. The as I told you, the tone, the power will be also difficult because of the hypertonia he is having. and the sensation or most of the sensation modality will be intact. Unless in the left side, at the same side of stroke, he might have some sensation affection. However, you can offer also for the conscious level GCS, maybe the patient is not cooperative. So you can start assessing his conscious level like this from the start. Okay. The heart, quick, and the liver, you can offer the liver for hepatitis B. I advise everyone to write the positive finding in the history in the paper in order not to miss it in the examination. They have criteria for judgment what the candidate picked up from that history and what he did in the examination. And according to this finding, they will judge on your performance. So whenever you have positive history in the finding, I mean in the history, write it. Then at the end, do examination for it quickly. So in this patient, as he's having or he had history of hepatitis B, I will offer at least offer the hepatic examination or liver examination and the chronic liver disease stigmata, quick as offer, and the ascites and so on. This is the message from any long clinical consultation. They have criteria. You have to fulfill all of this. So, for example, in FMF, I mean, my case in the exam was familial Mediterranean fever. The patient was having sinusitis, joint pain, abdominal pain. You have to examine the three things in the examination. Once you fulfill these, you will get good mark. I got almost full mark, 27 out of 28, because of this. And the candidate who didn't examine the joint, for example, they minus them. The candidate who didn't examine the abdomen, they minus them. So you have to do examination for the things you have or you had it from the history. This is the message from the clinical consultation. And please follow the stepwise manner of the history taking and finish your case scenario by examination. And don't forget the concern. But you did great, Dr. Azhar, as usual. This is my comment on this topic and for your performance. If you have any question or comment, you can add it, please.
And I did not ask, I forget to ask bowel and water work. Is there any significance in this case?
No, no, but sometimes, yes, if he's bedridden, he might have Foley's catheter. So don't
Yes.
miss these things, and it might be a clue there. You can have, as I said, Foley's catheter because he has incontinence, or due to inability or I mean disability, he will have Foley's catheter. He will be in retention, for example, or whatever the reason. But you have to offer it. System review mean even one question for each system more than enough in such conditions. Okay, just to show the examiner that you asked about every system. I know the time, sometime the time will be, I mean, not helping you to do, but at least try to offer one question for each system. So at least for the abdomen, you can say any change in the bowel habit, or in the UTI, or sorry, in genitourinary, you can ask any change in the water work. I guess this is quite enough for this system. It will not take time. Skin rash, joint pain, very quick also. One question for each system. Whenever you have a relevant system, the much and the more details in the relevant system. Like in this condition, you have to ask about CNS, the mood, the sleep, the abnormal movement, the behavior, everything in the CNS you have to ask in this scenario. But the irrelevant system you have to ask in a quick review. Okay?
I think I also should, regarding the investigation, I should also go for the LFT, RFT, and then
Yeah,
the
yeah,
blood
yeah,
sugar.
yeah. Yeah,
A1C, totally I forgot all these. Yes.
yes. But
With the
as you said,
practice, with the
eh,
practice.
of course, and this condition, it will be genetic. If he asks you one question for a specific investigation, as you said, genetic counseling or genetic investigation or genetic testing, this is the most diagnostic tool
Yes.
in this, yeah, to test and tool. But everything other than this, it will not help. It's just like basic baseline, as we said always. baseline, to rule out anemia, to rule out infection, to rule out electrolyte disturbance. Yeah, metabolic condition also here very important. He might be hypoglycemic or hyperglycemic, hypernatremic, hypercalcemic, or whatever. You can mention them, but the specific test important to mention here is genetic testing. And good thing also here, you give some advice to the son about the anticipation. However, it's not recommended to do the testing or the screening because it's not preventable disease. But you can touch it if he asked you. But if he didn't, you can skip it. Okay. Any other question?
From my side, no.
You want to add anything?
No, no.
Dr. Rabia, I will give you the mic now. I hope you are here. She's here.
Yes, Assalamu alaikum. Master
Walaikum
Dr. Basu,
assalam.
you spoke too much, so I don't think so there is any need to speak anymore. You explained the scenario and the disease very well. No much information needed. This is what we need in the cases. I would just like to comment because 65 years of age is a very it's a very elderly for the Huntington's
Elderly.
chorea to come,
Yes. Yes.
if he's having the family history, it should come a little bit early. I mean
Yes,
to say like
exactly.
40, 45, okay? So in
Yes.
this case, if this movement is coming for the first time, you should put stroke on the top, okay?
Yes.
I mean to say like it could be asymmetrical secondary to vascular event in the caudate nucleus, okay? So
Yes.
because he's diabetic, he's hypertensive, he's bedridden, okay? So this
Mhm.
could be the top differential. You can make it as genetic inquired, but the first differential will be second to vascular event, multi-infarct dementia, or multi-infarct, multi-infarct. This movement again to multiple infarctions in the brain due to diabetes, hypertension, okay, or the infarction involving the caudate area, okay, and then you can put a genetic cause like Huntington's chorea. But let's talk it like this: any movement disorder, you have to be like this. It's like a vitamins: vascular, inflammation, demyelination, trauma,
Ma,
autoimmune, malignancy, okay, and metabolic and drugs,
and
okay.
and
Mm.
nuclear.
So any movement disorders, you should make an abbreviation which is vitamins: V for vascular, I for inflammation, demyelination. You can put anything. T for trauma, A for autoimmune. If he's young age, you can put vasculitis, like Dr. Azhar said, SLE. Okay, and M for malignancy, I for infections. Okay, and T for toxins, like this. Okay.
And for new plastic and for
Yes,
new plastic.
paraneoplastic. Yes, paraneoplastic it involves. So these are the differentials for any movement disorder. His elderly, so you should put on the top is vascular or paraneoplastic. Okay, and then you can put everything else you want. Okay, Huntington's will come down the list. If he's young, 40, 45, then you have to put Huntington's on the top.
Yes.
Thank you,
Thank you.
thank you,
Thank you,
thank you,
Doctor.
doctor.
Thank you,
You're
Dr.
welcome.
Rabi.
You're welcome.
Thank you so much. Any question from others? Of course, rheumatic heart disease, one of the possible differential if the patient is young. Post-traumatic fever. Yeah, this was in the comments. Dr. Azhar, please write the case, please, for me. I
Okay.
will try to finish the comments. Yeah, I believe this patient should be younger than this, but I tried to make it as differential, to put stroke as one of the differential along with the drug. But Huntington will be younger than this, and it will be straightforward. I mean, nothing else. I hope they will bring the case like this. But once I try to make it more complicated, just to learn from it and to get the good differential to be ready for any exam scenario. Okay, other comments. Anyone has comments he can add, written or verbally? Yes, the hemiplegismus will be different. Yes, it will be all the arm moving away from the body, and it will be a stroke or infarction to the subthalamic area. Any question? Okay, waiting for the next scenario. Miss Rubina, 26 year, present with tiredness. Okay, give me just seconds to collect the thoughts, then we'll start. Okay, we can start, Dr. Azhar.
Okay. Yes, yes.
Okay, hello there, I'm Dr. Mukhtar, the doctor in the clinic today. You must be Miss Rubina.
Yes,
You are 26 years.
yes.
Yeah, we are here to discuss about your health issue. Is that okay for you?
It's okay.
Can you tell me what's your problem?
Doctor, I have tiredness, lack of energy.
Okay, I'm so sorry to hear about that. Can you tell me more about that? What you mean by lack of energy? You have some weakness, or you don't have the power to move?
Yes, yes, yes. I don't have any power. I don't want to work more. Always I'm lethargic.
Okay, again, I'm so sorry to hear about that, Mrs. Rubina. Can you tell me when exactly started?
It started 5 years before.
Okay, then did you notice this thing in worsening or improving or on and off?
No, the same. From the 5 years, it's same. But it comes and goes. Not all the time. Sometimes it is tiredness is there, and sometimes I'm in between. I'm totally normal, and then sometimes again I'm having this problem.
Okay, did you notice particular timing for for this symptom?
No, no particular time. Sometimes it settles for 8 to 14 days. Tiredness there. Then I have a gap of 20 days or 30 days. Then again I'm having this.
So it's a matter of days, not hours.
Yes, yes, days.
Okay. And what do you think something improve it?
Nothing. I did not notice anything that improves it. It
What
automatically relieves.
automatically? And something can worse it? Do you notice?
No, I did not notice anything.
Nothing. Okay. Apart from this, you have any other complaint I should be aware of?
Like what?
Like any past history of certain condition or you are diagnosed with
Yes, yes, I have been diagnosed with gallstones.
gallstones? And any, what did you do for that?
I did. I go to my doctor and he advised me for surgery. So I did the surgery 2 years
Uh,
before.
okay, and it was once,
Only for once.
yeah. And now you had the surgery, you remove the stone
Yes, yes, gallbladder.
and the gallbladder. Okay, okay. And it was what time the surgery?
2 years
Since
before.
2 years. Any other surgery you had?
No,
Okay. And you have any allergy to any medication?
no,
Did you receive blood before?
no.
Okay. And anyone told you you are paler than before?
Yes.
When exactly?
Exactly. Last same 5 years. Since 5 years, people are telling that you are coming. Sometimes you are paler, sometimes you are normal.
Okay. And you are taking medication for that?
No, I'm not taking any medication.
Any vitamins?
No, no, I'm not taking anything.
Yeah. And you confirm for me you didn't take blood.
Yes, yes, I did not take it.
You didn't take. Okay. Any family history of same condition?
Yes, my father, he was also having stone.
Yeah. And what diagnosis he had?
I do not know because uh, he
You
died
don't.
before
Okay.
my father had died. But my mother told that he was also having the same problem. Your father was also having the same problem.
Yeah, I'm so sorry for your loss, Mrs. Rubina.
Thank you
Uh,
very much.
can I ask you more question? Do you feel dizzy?
Yes, if I do any effort, I feel dizzy.
And when you stand from sitting, you have any dizziness?
No,
Did you fall
only
down?
only on exertion I
Okay.
feel dizzy.
Okay. Did you fall before or had trauma?
No,
Okay. You have any headache?
no,
Any pins and needles?
no,
Any weakness?
no.
How is your diet?
I'm taking all sort of diet.
Okay, you are not restricted to any diet, for example.
Yes, I'm taking all sort of diet.
Okay. And you have any weather preferences?
No,
Any vision problem?
no,
Any difficult swallowing?
no.
Any change of your skin color?
Sometimes I'm people are saying that you are yellowish, sometimes
And
normal.
for the same duration?
Yes, yes.
You
10 to
have any?
14 days, I'm yellowish, then again, I'm normal, then again, sometimes 1 month, 2 month, I'm again yellowish a little bit.
Okay. You have any itching, feeling of
No,
itching? Okay. Any tummy pain?
no,
Any change of your bowel habit?
no,
Any chest pain?
no.
Any short of breath?
When I'm doing some exertion, on exertion,
Okay. And when you're sleeping, how many pillows you are using?
I'm only taking one pillow.
Okay. And you are okay while you are sleeping. You don't awake at night to gasp for air?
No, no, no,
Nothing. Okay. Any leg swelling?
no.
Okay. Any awareness of your heartbeat or racing of the heartbeat?
Yes, when I do any exertion, on exertion, I'm heavy.
Okay. Okay. Any change of the water work?
No,
Is it change the color being more dark or
sometimes it's darker, sometimes it's it's normal.
okay. Any skin rash?
No,
Any joint pain?
no,
Any change of your appetite?
no, normal,
The weight?
normal.
Okay. And any lumps or bumps?
No,
Any body temperature, high body temperature?
no,
Night sweats?
no.
Okay. Do you smoke?
Sometimes I'm taking, but not regularly.
And do you drink alcohol?
Okay, I'm taking in the safe limit.
Okay. Till we have diagnosis, can I ask you to stop smoking and alcohol intake? It might harm your health. Is that okay for you?
Yes, it's okay for me.
Okay, what's your job
I'm a teacher.
and how the impact on your job
Yes,
of
it is
this?
affecting my job. It's affecting
Yeah.
because during the days of tiredness, I don't want to work. But during the
Okay.
days when I'm normal, I don't have any problem.
Okay, we'll try to help you in this regard. Any travel recently?
No.
You have partner?
Yes, I have.
Any change
But
of, sorry for this question, you have any change in the period?
no,
You are taking any birth control pills?
no,
Okay. Do you take any recreational drugs? Sorry for this question.
no,
Any sharing needles?
no,
Any tattooing or piercing?
no.
May I examine you?
Okay, yes, go ahead.
Yeah, what's the general appearance for the patient? Does she look
No, she
underweight?
she's average height, average weight, no deformity, no scar, and she's totally normal, fine, no shortness of breath at this time.
Okay. And now I will ask for the vitals, blood pressure, heart rate, and temperature.
Normal. Pulse 70, blood pressure 120 over 70.
And any change while standing? Any posture
No,
hypertension?
no, no
Nothing.
posture drop.
Okay, in the hand, any pallor?
Yes, sometimes pallor, sometimes normal.
There is no, there is pallor in the hand.
No, at this time, no.
No. And the
Oh,
pulse, how the
okay, we can say at this time. We can say at
okay,
this time.
how the pulse? Is it
Pulse
slow?
70,
Slow, the volume
normal,
pulse?
normal, regular, equal, no radio radial, no radio femoral delay.
Okay. Any proximal myopathy?
No.
The eye, any jaundice or pallor?
Yes, I pallor and also a little bit icterus.
Okay. Any, I will ask again back for the tremors. Any tremors?
No,
Fine or flapping? Nothing.
no, nothing.
Okay. Any raised GFP?
No,
Okay. You have any bleeding from anywhere, Mrs. Rubina? Sorry for
no,
the. Okay. Any black stool? Sorry for this question.
no.
Okay. I will examine the heart. Any murmur?
It's normal. S1, S2 normal. No murmur.
Normal. No murmur. No raised GPP. I will auscultate the chest.
Normal.
Normal. I will
No
examine
sign
the.
of breathing. No crackles.
Okay. I will examine the abdomen now for the scar first. Inspection. By inspection, the scars.
Okay. Nothing. No
There is
scar.
cholecystectomy.
Cholecystectomy. Sorry, cholecystectomy scar. Sorry, cholecystectomy.
Okay. The spleen is okay. Any splenomegaly?
Yes, splenomegaly. Spleen is there.
And the liver palpable?
Normal.
Normal. So only spleen. Okay.
Yes.
Any stigmata of chronic liver disease?
No.
Any ascites?
No.
Okay. I will offer for lymph nodes, inguinal and axillary.
Normal.
Normal. I will ask or offer for digital rectal examination
No
for
need.
any melena. Okay. The leg examination. Any
Normal.
any edema?
No, no.
Nothing. Sorry, I didn't ask for leukonychia or koilonychia. Is there?
No.
Nothing. Okay. Remind me when 2 minutes remains. I can't see the timer. Okay. So what's your concern, Mrs. Rubina?
What do you have?
Yeah, I appreciate your concern and thank you for sharing your condition with me. Uh, since I get the finding from your history and the examination, and since you have family history of same problem, you might have blood disease. Uh, it might be hereditary spherocytosis. Have you ever heard about this condition?
No.
Okay, so let me explain the disease for you if you don't mind. This condition, it might run in families, and always your bone or the area which the blood coming from, we are calling it bone marrow. It might be weak, and sometimes you have low blood
Two
count.
minutes left.
Yeah, so you have low blood count, and since you have these signs and symptoms, it's going more with low blood count in the form of dizziness, feeling tired most of the time, and also you have intolerance to the exercise. And also from the examination, I found some of enlarged like spleen, and you had also history of gallbladder removal after gallbladder stone. And this is my provisional diagnosis, and we have to run some blood tests to confirm the diagnosis and rule out other possible causes. Do you have any other concern?
Yes, doctor. Sometimes I'm taking fava beans. I'm then after taking these, I'm thinking I have more weakness after taking fava beans. Is there any relation of these fava beans with my condition?
Yeah, this is one of the other possible conditions. It might be related to your food intake, and it's protein in your blood deficient. Once you have this deficiency in your protein, the condition might happen after eating some proteins. So we have also to run some blood tests to confirm this diagnosis and to rule out the others. You have any other concern?
Okay, is it curable?
I'm afraid to say it's not curable, but it's controllable. Once you avoid this fava beans, it might improve your condition, and you might not have this attacks again.
Okay, will this condition transfer to my kids? And what will be the percentage?
Yeah, I appreciate your concern, and your question is valid. Yes, it's one of the familiar condition. It might transfer to your kids in the form of X-linked recessive. Don't bother about the name. If your kids had the gene or the code from you, they will have the disease along with
The percentage in my
yeah,
daughter and son.
the percentage in each daughter, it will be like the daughter will be 50% or
And
25, and they will be a carrier if they have the gene from from you. If the father having the disease, it will be 100%.
and what about my son?
The son, the
Time up.
possibility is 50%.
Time finished. 1 minute over.
Yeah, 50%. Yeah, difficult question, but I am trying to calculate it. Yeah, but right question, yes. X, I think X recessive, right? X recessive.
Yeah, yeah, excellent.
X linked recessive,
Can
so
finish
it
That-
all
will.
concern of can finish all
Oh,
concern after time.
Okay, okay, we
Maybe
will go further.
okay,
Examiner
let's do it
question.
yes,
later. Yes. Okay,
Then we
benefit
let's.
will
for us.
continue. Then we will
Let's.
continue.
Okay,
Okay,
later.
please present your case.
Yeah, Rubina, she is 26 years, came with attacks of tiredness on and off, and recently she found that it's related to certain types of food, which is fava beans. And after taking the history, she had history of cholecystectomy. She had family history of the same condition. Apart from this, on the examination, I found signs and symptom signs suggestive of anemia in the form of posture hypotension and also pallor in the eyes and in the palm. Apart from this, I found also splenomegaly while examining the abdomen and the scars for for the cholecystectomy. So collecting this data and putting this together, this patient had most probably glucose 6 phosphate dehydrogenase deficiency on the top of my differential.
What will be your differentials?
Yeah, my differential other cause of anemia. However, she denied any blood transfusion, so I could think about hemolytic anemia like thalassemia or hereditary spherocytosis.
Very good. And then how you will investigate this?
Yes, basing investigation in the form of CBC to check for anemia if she has, and the MCH to find the kind of anemia. Apart from this, other liver function and kidney function electrolyte coagulation profile just for screening. However, it might be normal. The most important here specific test to do is the enzyme assay, glucose 6 phosphate dehydrogenase assay in the blood. And
And
I
what
guess,
about the
yeah,
hemolysis screening? Hemolysis screening you will
yeah,
do?
hemolysis, of course, hemolysis work up when the patient has the attacks of hemolysis after the food, I mean, intake or protein. So I will look for LDH, total and direct bilirubin, and other COMS test, and other hemolysis workup.
And what about retic count?
Retic count also during the attack.
It will be low or
It will
high
be high.
in during attack. And
More than
haptoglobin?
haptoglobin will be low during the attack as well.
Okay. And then to confirm the diagnosis, will you do any specific test?
Yeah, enzymatic and genetic testing.
Very good. Okay. And you will also go for any scan, abdominal
Yeah,
scan.
imaging. I could do ultrasound abdomen for splenomegaly and to check for any hepatic involvement.
How you will differentiate between hereditary spherocytosis on the basis of history and glucose 6 phosphate dehydrogenase deficiency on the
Yeah,
basis of
in the history, the patient will receive blood, but in glucose 6-phosphate dehydrogenase, patient will have no blood transfusion in the past.
and and something else you want to add? The tiredness will be on continuous basis or comes and goes.
In hereditary spherocytosis will be much frequent than the glucose 6-phosphate dehydrogenase.
Yes, yes, because in this hemolytic, this glucose 6 phosphate, when he taking fawabin, he is having problem. So
Yes,
it is episodic. In
yeah,
heredity, it may be continue.
continuous, yes.
Okay, then what about the kids? This X-link usually in males or females?
So it's male to male transfer. Whenever the father is having the gene, so he will transfer to all of his son. But in the female condition, the possibility will be less. The daughter will be might be carrier than being affected or diseased, since she is taking X from her father and X from the mother. So the possibility will be 25%.
It's rare in females, but exceptionally it can be in females. If in females, then the chances to the daughter will be 50% and to the son will be 100%.
If the gene transmitted from the mother and the X, I mean the X from the mother, yeah, it will be 100%.
How
Because the
you
mother,
and how will you treat?
yes, most probably multidisciplinary team approaches starting by the gastrologist, hematologist, genetic counselor team, and specialized nurse, social worker. The most important here is lifestyle modification. I mean, avoiding of the trigger, which is fava beans, counseling, education about the complication of anemia, and the red flag, safety netting about the hemolysis attacks, how to prevent and how to avoid the complication, and to seek medical advice immediately if she feel any change in her GI symptoms, I mean any GI upset or
Very good.
feeling unwell. Apart from this, no specific pharmacological therapy.
Will you go for the splenectomy?
Splenectomy whenever the patient is having huge splenomegaly or if there is abdominal pain and fullness. But usually we are not doing it.
Not in hemolytic. In this anemia, we will not go. But in hereditary spherocytosis, will you go for
Yes, mostly. Yeah, because the glucose 6-phosphate is intravascular hemolysis, but in hereditary, it's extravascular in the spleen happened.
yes. And if the once you have attack with fava beans, for how many days it will continue
Uh,
if
I'm
you
not
will
sure,
not
but
take any treatment?
yes,
8 to
I'm not
14 days. 8 to 14 days. 8 to 14 days.
2 weeks. Okay, 2 weeks.
It
Okay,
is self-limiting,
self-limiting.
self-limiting, and
Yes.
it will continue for 8 to 14 days.
Mhm.
Okay. Will you give any treatment for anemia?
I guess there is vitamins. We can give vitamins, multivitamins for
No specific treatment according to the
no
condition of the
specific.
patient and investigation.
No.
And on the history, as I told you that I'm having dizziness on exertion, I'm
Yes.
having racing of the heart on exertion, I'm having shortness of breath on exertion. What does it mean?
Yeah, it means the anemia signs is
Very good. Symptomatic
symptomatic.
anemia.
Yeah, symptomatic anemia.
DRS, dizziness, racing of the heart, as shortness of breath. DRS,
Mhm.
this patient has been complicated by symptomatic anemia, not any organic disease. Thank you very much. Thank you very much. Very nice. You presented the case very nicely, and in the history you did not forget anything. But only whenever why I brought this case, always you are telling, yeah, I'm forgetting about this anemia.
Yeah.
Are you listening well? That's why I brought, and you asked all the questions like about the periods, about my diet, family history. But one thing you will add in your history,
Yeah,
uh, fava beans, because
probably yes.
in this, if you will ask, if I will ask, inform you that I'm having problem with the fava beans, then the case will finish within 1 minute.
Yes, exactly. Yes.
Okay, one more question, if you can agree. One more question. Can I ask you
Yeah,
what
sure.
is what is favism? What is?
The favism itself,
Yes, yes, yes.
yeah, I guess it's the severe form of the glucose 6 phosphate dehydrogenase. I'm not sure, but
Uh, you see, favism means that if I take fava beans and I develop all the signs and symptoms of this disease, we will say I am having favism. And if we will do the test for glucose 6 phosphate, it will be deficient. It will be deficient.
okay,
But all the patients who is having glucose 6 phosphate dehydrogenase deficiency, they will not show favism. Means,
okay,
well, if there are 100 patients of G6,
yes,
only some patient they will show favism, and if any patient will show favism, definitely the underlying cause will be glucose G6.
yeah,
But
I
if
got it.
any patient is having G6 phosphate, it's not necessary that he can show favism.
Yes, I got
Okay,
it.
thank you very
Yes,
much. Now you can add from your side, but you will add one buzzword. Okay,
yeah, I will add one comment only. If the positive travel history, if the patient having travel history positive, what do you think the clue in the case? This question for you. You got it? Patient had history of travel, and when she traveled or after she came back, she had this hemolysis attack. What do you think? Is it clue for the case, Dr. Azhar?
yeah, yes, maybe something malaria like.
Excellent. Yeah. So, what malaria exactly?
Yes.
The
Consider.
anti-malaria. No, the anti-malaria medication.
Okay, okay. Anti-malaria. Okay.
Yeah, it's also called the same problem.
Hemolytic anemia.
No, glucose 6 phosphate dehydrogenase. I mean, yes.
Yes, anti-malarial. Yes, they can cause. Ciprofloxacin may cause. Yes,
Yes,
yes.
exactly. This is another clue for the case. I mean,
I
but
think
it's
You are
Primaquine, especially
Brimaquine. Yes,
anti-malaria cause.
Brimaquine.
prima.
Yes. Yeah, this is the only comment I can add. I will ask you now again for the genetic and the X-linked, how you can explain it again, because I said if the mother having the X, so the possibility for the daughter would be like carrier only, right?
Yes.
But once the father is having the X, the the daughter, I guess it will be more susceptible for the disease, or I am wrong.
You see, I'm also always confused about these
Okay,
X-linked
let's
receptors.
repeat it again. If the son took the take the X from mother and the Y,
Mhm.
of course, from the father, the son will be manifested because
Yes,
he has XY and the X will be diseased.
yes.
But
So,
the daughter will have only carrier since she's taking X from the father, the mother, and X from the father.
mm,
So the son will be more manifested whenever he has the X from the mother.
yes, yes, yes. That's why I told you the sun will has
Can I
100%.
say something?
Yes, sure.
An X-linked disease
the father can't give um, the character to the son. Father cannot give it to the son. The son get it from the mother, which carry it from her family or her brothers.
Yes.
Okay,
Mhm.
the mother and the daughter is a carrier who as it she
Yes.
can get it from the father. Um, Female have this character in very a small way or not
Yeah.
very manifest.
Few percentage.
Ha-
Yes.
okay,
Mhm.
it can have the full blown picture if she is X zero Turner, I mean, or in on a community with increased prevalence of the disease.
Yes.
Okay, so the
Mhm.
father cannot give the character to the son. He can give it to the daughter only. And she is a carrier and cannot have the full blown picture unless she is Turner or in very high prevalence of the disease.
Yes. Yes.
Okay.
Okay. Thank you, Dr. Sar. Thank you. Okay. I guess it's clear now. So the daughter mostly she will be a carrier, but once the son get the X from the mother, he will be diseased.
Yes.
Yes. Okay. Thank you,
But
Dr.
in the exam, if anyone asks what is the percentage if they are asking.
I guess
So,
25. Still 25. It's the carrier mean 25%.
but I have read in the book about this scenario. It's
Okay.
clearly written:
Uh-huh.
female 50% and son 100%.
The son, whenever he had the X from the mother, but the mother take care. The mother is two X, right? X and X. If
Yes, yes.
the son got the healthy X, he will be okay and healthy. So it's 50 now.
Actually, this disease is rare in female. But if in females, then the
Carrier.
percentage will be reversed. It's written
All,
in the book.
yeah, always the females are carrier
Yes, yes,
because they should have two X to have the disease. Meaning that the father and mother should have the disease, and the
yes,
daughter will get X from the father and X from the mother, then she will have the disease.
yes,
But other than this, that the daughter will have X from the mother and the healthy father, she will never had the disease. She will be only carrier. This
yes,
is what
yes,
I remember also from part one and part two. But
yes, yes, yes.
the son, once the son got the X from from the mother, of course the Y from the father, he will have the disease. But if the father is diseased one and the mother is healthy, so the father will have the X. The daughter might have also carrier. She will be carrier because she will get the X from the father and X from the mother.
Yes,
But the sons will never have the disease because it's not he's getting the Y from the father and the father is diseased, so he get Y from the father and X intact from the mother, so he will be intact. So it's not
okay.
transferred from male to male.
Yes, yes.
Yeah, this I said the opposite, male to male. No, it's not male to male.
Yeah, male to male, not transferred.
Yeah, not transfer from male to male. Yes, exactly. Okay, good case, Doctor Azhar. Always you are giving us new scenarios and new diagnoses and new conditions. I had, I think, 25 comment. I didn't read all of them. So let's call Dr. Abdullah and Dr. Sarah. And if anyone has comment, he can add it verbally until I will read the comment. Please, you can share your comment verbally before starting the second session. I mean the communication. Dr. Sarah, Dr.
Doctor,
Abdullah. Yes.
Assalamu alaikum, Doctor.
Alaikum assalam.
This one, the scenario today, the last scenario you discussed, looks
Mm.
like the travel was like for the towards the hereditary spherocytosis until the history of our being allergy came.
Yes, yes,
Because
exactly.
in the history, of course, unfortunately, you missed the history of allergy in the diet. But you asked about the diet, vegan
I
diet.
asked about the allergy and asked about the diet, but
Yeah,
suppose
yeah,
he will not
because.
tell you. Yeah, yeah. If
Mm,
he told me, I will get the
mm,
case. Yes.
mm, mm, mm. Because I was traveling with you in the history towards hereditary spherocytosis because of the
Yeah,
cholecystectomy. Of course,
yeah,
the blood transfusion was missed here. Blood transfusion was not there. Recurrent blood transfusion not there.
yeah,
And
exactly.
middle-aged man, of course, with a family history positive, was going towards the hereditary spherocytosis until GCSP, fava bean allergy.
Yes,
So, and you changed totally the diagnosis when you presented the topmost provisional diagnosis as a
yes,
G6PD.
yes.
So I got confused here. How to travel like this?
It's okay, by the way, if you didn't reach the diagnosis and the
Mm,
examiner felt that you approach the case well,
mm,
even at the end, you catch the diagnosis at the end, he will give
mm,
you good mark.
mm,
Especially,
mm,
especially
mm,
if the case scenario is difficult, like this scenario. It's not
mm,
common case, but for the common cases, they are judging you more hard because you have to know the diagnosis from the start.
mm,
So,
mm,
however, you have
mm,
difficult scenario, they will judge on the approach and the history taking and examination and so on. Even if you don't reach to diagnosis at the top,
mm,
but
mm,
you could put it in the differential, they
mm,
can judge you well. They will give you good mark. So you
mm,
have to put it in the not in the first differential, but you can put it in the second differential. You
mm.
can get the mark. Even the
Okay.
examiner can ask you some question to give you a clue, and you can give him the case and the diagnosis. He will give you good mark.
Mm, mm,
In one
mm,
occasion, you have
mm,
to take good history, step wise manner and systematic way, and don't miss any social, not, don't miss any occupational, plus the good examination. I
mm.
guess they will give you good mark.
Yeah. And if you feel that the history is getting prolonged, can we just go ahead and start to examine the patient, and in between we
Yes,
can
sure,
ask the
sure.
question?
Yeah, you can.
Can be asked.
Yeah, yeah.
And second thing in examination, as the systematic approach, looking for the
Mm-hmm.
liquid nails, palmar erythemas,
Mm-hmm.
jaundice, AV fistula, BP, pulse, JVP, carotids, palar, jaundice, and
Mm-hmm.
parotid enlargement. In the proximal myopathy examination, you ask the patient to shrug the shoulder against the resistance. Do we
Yeah,
allow to do the gait examination to get up from the bed for the proximal examination, or no need?
you
Proximal
can
myopathy.
ask. You can ask, and if they said no, doctor, you can skip.
Mm-hmm.
So yeah, if the patient, for example, on the bed,
Mm,
it's difficult to tell him, please, can you stand from sitting because he's already
mm,
lying flat. But you
mm,
can do the proximity of the shoulder. Ask
mm,
him, please, can you raise against my arms or my
mm,
hands?
mm,
It will be also diagnostic for proximity.
mm. Because tiredness is a general term. It can be either anemia
Yes,
only, or can be endocrine also, or periods also. It
exactly.
is generally, even some drugs can, even diuretics can
Of,
also will cause cardiac
of
cause, also
course.
will cause pulmonary hypertension, will cause. It is a general
Yeah.
approach.
Let me tell you that when I start the case, I put differential as chronic fatigue syndrome,
Mm,
fibromyalgia, and SLE or multiple sclerosis as fatigue or
mm,
tiredness.
mm,
But
mm,
you
mm,
see, you change the total differential because of the scenario, history, and examination.
mm.
But you're right.
Yes, doctor.
Some, yeah, this
Mm,
condition can be as a cause.
Dr.
mm,
Basim,
mm.
can I add something?
Yes, nice, doctor. Thank you.
Thank you,
Uh,
Doctor. Yes, Dr. Azhar.
in this case, with when we are facing any case of this anemia with diet, periods, past history, we will add one about this blood transfusion, and then we will add this fava beans. Maybe they are writing.
Yeah, yeah,
And
yeah. You're
if
right.
there's any case of tiredness, there is I will describe a little bit scheme. If
Mm-hmm.
tiredness all the time, all that immediately we will ask the question, what about the weight? If weight is normal, and then you will ask about appetite. Weight, appetite normal, then you will think about anemia, depression, stress, fibromyalgia, like this. But if the
Mm-hmm.
weight is decreasing, then you will ask the appetite. If appetite is intact and weight is decreased, then mostly three, four things you will go for the uncontrolled diabetes, pseudochromocytoma, thyrotoxicosis, IBD, celiac disease. But if the
Yes.
weight is low, and diet is
Appet-
also appetite
Appetite
is
is
also
low.
poor, then you will go for the chronic diseases, chronic
Cancer
vasculitis, and
and
then
cancer.
malignancy infections.
Yeah.
So if you will make this scheme immediately, you will not be misguided.
Yes, you're right. So is the weight here and the appetite will be clue. Always
Weight,
ask about
appetite
the.
normal, anemia, depression, fibromyalgia, like this.
Yes, yes. By the way, you will have positive finding while taking history. Every case scenario will have clue, and once you get this clue, you will go through the differential of this
Yes,
diagnosis.
yes, yes.
Yeah, I mean, for example, fibromyalgia, chronic fatigue, you will have the clue of feeling tired, the low mood, less sleep, some infection, lymph node, feeling of lumps or bumps. So you will think about chronic fatigue, some tender point, fibromyalgia, and so on. This is the way how to approach and how to reach to the possible diagnosis. Okay.
Yes, yes, yes,
Thank
yes.
you so much, Dr. Azhar, for the case and nice presentation for this scenario. Dr. Sarah, you ready? I will read the scenario for Dr. Sarah and for all of you. Mrs. Zia, 68 years old male, involved in a road traffic accident and presented to the emergency in a critical ill condition despite immediate intervention and the initiation of mechanical ventilation. His condition did not improve. Following a thorough assessment, the medical team has determined that Mr. Zaya is brain dead. Given this diagnosis, organ donation has been considered as potential option for him. Your task is to counsel his son, Mr. Ahmed, regarding organ donation. And thank you, Doctor. Also, Dr. Sarah, you're here.
Okay.
Yes, I'm here.
Can you send in the group also? Very difficult to read here.
Yeah, it's in the group. By the way, I got it from the group. I take it and I copy it.
Thank you.
Dr. Sarah, I will give you 1 minute just to read the comments, then we will start straight away, okay?
Okay.
So let's go back to the, yes, glucose 6-phosphate dehydrogenase. Time is up. Thank you, Dr. Samah, for reminding. Tiredness in young female from outside. Anemia, hemolytic or others. Addison, hypothyroidism. Rest of autoimmune, yes. Connective tissue disease. Sjogren, myasthenia gravis, TB, infective endocarditis, lymphoma, leukemia, yes. And hepato plus or minus, splenomegaly, jaundice, pallor, chronic liver disease, stigmata. So chronic liver, if no stigmata, so hemolytic anemia, exactly. Hepato plus splenomegaly plus pallor with no jaundice, infection or lymphoma or leukemia, yes, exactly. Thank you, Dr. Noor. Dr. Samah mentioned also the EMA for binding for the hereditary spherocytosis as diagnostic tool, yes, plus the analysis of the blood or doing blood film. History more suggests hereditary spherocytosis exactly, but you see that the clue was at the end. Turner and female XO, exactly, so she might have the disease, definitely 100% she will get the disease. Okay, Dr. Sarah, no female, only Turner. Okay, medication, yes, she female, but inherited disease like male. Only transfusion, folic acid needed in glucose 6-phosphate. I guess you can add all multivitamins just for a replacement and improving of the, and I mean, regeneration of the blood, make it quick and fast to replace the destroyed or hemolyzed blood. Well done, as usual. Thank you, Dr. Samah. Hemolytic after malaria, yes. Primakin. Okay, agree. Female is a carrier. Transmitted to son or affected daughter will be 50 as a carrier. There is a chance. One more. We will discuss this in the group more about the X-linked recessive and X-linked dominance. Antibiotics, particularly Cotrimazole, Bactrim, sulfa, of course, sulfa, very important. Anti-malaria, hydroxychloroquine, quinine, and quinine, hydroxychloroquine, and chloroquine and quinine. Chemicals, most methylene blue, fava beans known as broad beans, stress from bacterial or viral infection trigger of glucose 6-phosphate dehydrogenase. Thank you, Dr. Noor. Let's start, Dr. Sarah. Ready?
Okay.
Yeah, here you go.
Yeah.
Hello.
Hello.
My name is Dr. Mahmoud. I'm one of the doctor here in the ward. Am I talking to the next of kin of Mr. Zia?
Yes, I am, doctor.
Yes, I'm here to talk to you about your father's condition. Did anyone talk with you before me? One of the doctors talk with you regarding your father and update you regarding his condition?
No.
Okay, so I'm here to talk to you about him. But can you tell me first, at the first place, how much do you know about your father's condition in order to be on the same page?
Yes, doctor. My father, I know he had this accident and he came straight to the hospital. He was not in a good state. That's what I know about him.
Yes, I really appreciate your concern. That's right. Your father came to, after having a road accident, he came in, he was very seriously ill. And we tried to put him on a breathing machine. We tried to resuscitate him, but unfortunately, I don't have good news for you.
What do you mean, doctor?
I'm really sorry to tell you that your father is dead, and he's not responding.
Oh my God.
So I'm really sorry about breaking this news to you.
What do you mean not responding?
Yes, it means that despite all our effort to resuscitate him, he's not responding, and our consultant has examined him. We have two consultants that they have examined him, and they confirmed that his brain is dead. It means that he's clinically dead.
Oh my God.
Yes, I'm really sorry.
Doctor, I don't understand. Like,
Yes,
how is brain dead? What exactly do you mean?
yes. Let me explain for you. So when we confirm that there is death in the brain, it means that if we remove all the mechanical machine, your father is dead and has passed away. So this is a confirmation of death.
Doctor, what is mechanical?
The artificial machine, I'm saying.
Doctor, is he dead or not? I'm so in shock.
Yes, your father. I'm sorry to tell you, and I'm afraid to tell you that your father has passed away.
Okay. Oh my God.
I'm really sorry.
But why you say machine and I don't understand.
Yes,
What
I'm trying to explain for you that when your father came to the hospital, we tried to resuscitate him. We put him on a artificial breathing machine, but he's not responding.
Okay.
And then the consultant has confirmed his death.
Okay. So, but okay, like, but he is here 2-3 days. Like, why you're telling me today?
Because we have confirmed his death, his brain, that he has died now. So I'm coming to you to update you, to tell you about his condition. And we have.
Why I'm not updated 2 days ago when he started to be like that?
He started today.
Okay.
So when the consultant has confirmed that he has died, so I was asked to come to update you and to tell you about what happened and to beg for you.
Why the consultant doesn't do that yesterday? Like, what's the difference? If my father is not responding.
No, he at the beginning we tried to give him all the medication and try to give him all the treatment. And we did all our effort to resuscitate him, but today we discovered that he's not responding, and
What resuscitate you mean?
tried to save him. We tried to save him,
Okay.
and when we we stopped all the medication. He's not responding. So the consultant has confirmed that as he's not responding, it means that his brain has died. So it means that he has died, clinically died.
But what about his heart? Like, is he alive or not? You're confusing me, doctor. Like you say, brain die. What is the difference? Like, is he?
It means that he has died. He's not responding. He's only still on the machines, but he has died. When the brain is died, it means that the patient has died.
Oh, but doctor, I heard that there are. I'm quite concerned because I hear that some people they may get some recovery, something like that, after a long time, even if they are put on this. He is in critical care. Like this is the best place, so he can. Um, like some people can recover then slowly, but they recover. Like they're not dead, and then they open their eye. I saw that in the
I
news, and I know that.
I really appreciate all your concern and can see how are you feeling now. But the issue is that when there's brain death, it means that the brain is totally died, so it couldn't recover again. When you are talking this patient that they have some recovery, they have still the brain is not died. But in your father condition, your brain is completely not functioning and he died. That's why we say that we confirm the death by having that the brain. I'm really sorry.
Okay.
I can see that I gave you a lot to take today, but I just want to talk to you. If your father still, I think that your father, if he's alive, he will be happy to help other people. So that's why I want to discuss with you about the organ donation. Have you heard about that?
Yeah, but I never want this. Like this is like I just came. I wasn't expecting that you telling me that he died. I was like at least I should prepare myself. And now you're telling me donation. Like this is so much crazy.
I'm
I
really sorry.
don't know.
Yes, I'm sorry that I give you a lot of shocking news, and this too much to have it. But I will. I'm just only asking you. You can have your time to think about that. But I just want to explain for you what is meant by organ donation, and if you are happy, if you give us the consent to proceed with that. If you don't give us the consent,
Like what is it? What should I know? Why
yes.
you're telling me that now?
So when a patient has a brain death,
2 minutes left.
we can proceed if the family accept to have the organ donation. So we can ask the organ donation team to donate their organs to critically ill patient and to save their life. So that's why I'm asking you.
Why he should donate himself? Why it is? I hear they keep freezing the bodies and then they can find this. Like it's not a difficult thing.
Sorry, can you say?
Yeah, like I hear it is. It shouldn't. Like why you're telling me this now?
Because if you accept to do that, I know this is a difficult time to talk to give you all this information and to talk to you in such situation. But if you accept to and give us the consent, we can proceed by the organ donation team to come to proceed with that.
No, I don't accept.
Okay, this is all your right. If you don't want to accept to do that, but
Okay.
if you want to have a think, and if you
Okay.
want, we won't do it because we are respecting you and you have the right to accept or decline that.
Okay.
Okay. Do you have any other question? for me.
Should I bring my family now to say goodbye to my dad?
Yes, yes, please. You can bring all your family, and we can also give you all the support. We have the bereavement team, so they can give you all the
Okay.
support. I'm really sorry to give you such bad news. And my condolences.
Okay, time is up.
Okay.
Okay, time's up. Just
So, yeah.
yes,
So
you can
first,
start comment.
so it's a difficult scenario actually. So you will start first by a very empathetic way, ask for anybody to attend with you or not, and then because you are preparing something very, very tough, and then so in the first 2 minutes you should finish the thing of the explaining the dead and brain dead in a quick manner. How to do that? Like so. You should bring the prepare the scenario like so tell him the events what happened. So he was in a critical case. So he doesn't know anything. So after road traffic accident, he was very bad, and then he brought to the critical care. In the critical care, we were observing all the teams on a daily basis. He's in a continuous monitor with the critical doctors. They're inside the critical care, and he wasn't he was in a non-responsive status from the beginning, or according to the scenario. So, and then he wasn't improving at all from the beginning after this road traffic accident. I'm really sorry to tell you that. We were keeping observing him on that day-to-day basis, hopefully if he may improve. So this is a question that will explain when I asked you, why did you think about that today or yesterday? Like the family is not understanding why this happened now, why you didn't tell me the first day or second day, because I don't understand this assessment and all that stuff. So you say we're observing, hopefully if he may improve, but he will not improving at all, and he was in a really bad status, and we were giving all the support that needed, and we were doing all the medical treatment that he may need, supporting his blood pressure, supporting breathing with breathing machine. We did all what should we be doing, but he, after no responsiveness and at all in the later days, we assist on him and our consultants, and I'm really sorry. We found that um, he is he is no longer with us. In a simple way, like he is he's not responsive, and he's no longer with us. Or he is brain dead. Well, brain dead will make confusing. You say he's not with us, or what do you mean he's not? Yes, we assist on him. Let me tell you, he is just on the breathing machine, supporting, making his heart and lungs moving, but his brain is not functioning, and he is brain dead. And this equals, and then you will silent. You should have two silence. So you should prepare. I am sorry, I'm delivering no good news here. He's dead. So we assist on him, and because he's brain dead, and only the machines are keeping him moving his chest and heart bumping. Doctor, like, is he alive or not? Because the brain controls all the body, and the brain is dead, and his brain is dead. So immediately, if we take the machines off at any moment, he will stop anything. He will stop the breathing. He will stop his heart beating. So this is equal to death. I'm sorry. This is so sad and traumatic to you. And so he will start now. So he will be angry and traumatized, and then he will shift now. He will be able to shift to the organ donation because you will say, I'm sorry to tell you, I know this is very sad moment, but I need to speak with you about something that I want to tell you now. Something I know you said a good way. Your father is your father. I'm sure you want your father. You know your father is a helping person, and and you want you and you know him that he was great to others and helpful to others, and I want to tell you that we are planning to discuss something related to organ donation. Did you hear about that? No, I didn't hear about that. And why you are bringing this now at the moment? It's actually we need. I want to discuss with you that this is a suitable time because your father's. I'm really sorry to say that like this way, but in your case, I know your father. If you want your father to be able to help others, this is the best way because his organs are warm, and this is the time to discuss about this issue. And I'm sorry it will be like this way, and we need to go forward with this issue and discuss with you as a family. So he will refuse, but you will say, I'm sorry to tell you that. So first you'll go to the benefits. Imagine that your father's breathing is going to somebody in need. Imagine that your father's heart is still pumping in our life. Imagine that your father's kidneys are working and still there in somebody else, helping his kidneys. No, I refuse. It's not his option. The new guideline now is anyone can donate, can be organ donor. It's not the families. This is in UK guidelines in 2020. Anyone is organ donor unless he refused, opted out. So there is an opt out form. So there is something called opt.
No, the family can refuse. The family has the right to refuse.
Yes, I guess still, Dr. Abdullah.
No, if the patient has advance directive will to donate the organs, I think the family has no rights to do that.
No. Still,
No.
there is emotional consideration for the family. So
No.
they will try to convince the family, but still, it's not like by
No.
force.
No. If
It,
didn't keep a will that he want to do, has a card of organ donation, and the family using, so they will respect the family.
No. They canceled that, and we can review these guidelines together if you want. So what I know is that there is a new guidelines now, which is not new, like 4 years ago now. The UK now, because they don't find any.
So I'm doing this will, and we discuss this with my family. So the family can refuse the organ donation. So I'm quite sure about this. You couldn't force anyone for organ donation. If the family refused, so you will respect the family.
Yeah, it's again family wish, doctor. Yeah, although there is acceptance from the patient himself, even card, they can get even verbally consent for the acceptance. This is what I
It's
know
a
also.
verbal, but it's not there. They cannot refuse this thing now in UK. So
No, still they can refuse. Still. But they are working on the convenience, so they can convince the family, but not to force them. You don't have
convince.
right to refuse.
Yeah, you don't confront. Yeah, but it's not their option, by the way. Like, even if they refuse eventually, um, you will say, we're sorry, like, we need to go forward. We need to go forward. If, like, if that was his, if he didn't refuse, like he didn't refuse before, or he didn't have an opt out, I'm sorry, like we may go forward for that. You will prepare them just by telling them.
Dr.
So
Abdullah,
you tell the family.
yeah, you tell, but not as no option, no choice. No, still they have to accept it. This is also what I know, and I'm still updated regarding. And Dr. Sarah also there in UK,
Well,
she can ask and confirm
yeah,
for us.
yeah, we really need to know that.
Yeah,
But I know that it has been recently changed because there was scarce, in availability of organs because of this, so that they changed the rule. So they make everyone is, yeah, I know that, and I read about that also. Like, everyone is for organ donation except if they are opted out, which is less than 18-year old, or in less than 1 year in UK resident, or if he uh, uh, if he is opted out, or less than 18, or less than 1 year in UK resident. These are the three conditions which make you opted out. Otherwise, you are automatically in the system for donation. That's the system.
yeah, but
Yes, you are automatically for the system organ donation, but if the family refuses,
Okay.
they can accept that. Okay, so this is that I know.
yeah, this is also what I guess. Whenever there is family, they have to review the family. But if no family, as you said, he will be by default as donor. If he is isolated, they don't reach
Okay,
to his
Dr.
family.
Bassem,
Yeah,
what is, like, this is a very logical thing that the family will come and discuss. Like, everyone dying, like, he will be with the family, discuss.
yes.
If they put family refusal as an issue, then, like, there's no benefit of this rule.
By the way, I read a
We
case
should revise. Okay.
couple of days ago. They labeled patient as brain dead, and when the patient was for donation in the surgery, he opened his eyes, and it was a big dilemma. And they review the policy again because they have to confirm the brain death
Brandon.
before doing this. And also, by this way, they will change the policy for the family issue. If by default they will take any patient there, every patient will be taken to the OR and they will harvest the organ. But what I know, they have to talk to the family. Okay, even if the family refuse, they will convince them. By the way, here also in the Gulf, they are doing the same way. They are convincing the family one and twice and thrice. If the family is still refusing, they will not take the organs. And also by logic, if you think about it, do you think they will force family to harm the dead person by cutting the organs, cutting the without their
But they,
acceptance? Emotionally, it's
why they
very
put, like, why they
yes
put this rule? Like, it
rule
doesn't make sense.
role for the isolated person, like he doesn't have family sitting, because if they will not reach to the family, they will harvesting him. But if they have family, they will try to convince. Yeah, he is candidate, but he should also, or they should respect the family wish. This is what I know, and also Dr. Sarah said, and Dr. Noor also confirmed this. By the way, in the
Okay.
exam way, I don't think you can say to the son, this is no choice to get permission from you. By any way,
No,
we will
no, I
take.
didn't say like that. No, no,
Yes,
no, no, I didn't say like that. But you'll say,
I sent a document on the group now. It's written, the clinician will never
can you
proceed
share it?
in donation if your family or loved one object. Okay.
Is that updated?
Yes, because yes, I know what.
Okay.
Okay, the issues. I think you might mean that if the patient has a document that he want to donate his organ, and the family objects, doesn't have the right to object on that. The patient gave a card for organ donation. The family couldn't say no, we don't want to give. They will have. But I think the opposite. No,
Yes.
everyone considered in the UK for organ donation, apart from the people that if the family refused. Because for me, I was right. I want right will that I don't want to donate my organs, and they told me no need. If one of the family object, you won't donate your organs, because you need to write will for your money, for your house, and for your organ donation. So I was say I asked about this before for myself. That's why I don't, it's maybe it has been changed, but this is I was thinking to do a will to, because I don't want to be my organ to be donated. They told me no need. If one of your family object, they have the right.
Yes, I agree for this.
Yes, so I asked about this, and I'm quite sure.
Okay, let's take the positive thing from the card issue, Dr. Abdullah. So the card issue, as Dr. Sarah said, yes, the person will say, I am organ donor whenever I am not here anymore. That time they will contact the family and they will convince he is agreed for the donation. So we are trying here to talk about this issue. But I can't say by any mean we will take his organs. We have to give them some time to think and to get the permission, as long as he already agreed for that. You got it. So we can convince, and we took it as weapon to convince the family he is agreed for this, and he already clicked for that. But if they said no, we will not accept, this is their right as well.
So the patient will not donate the organs, even though if he has advanced directive will card.
Yeah, we will get it as a positive document that we will try to convince you as long as he is accepting that. You got it. So it's like
the patient agreed to donate the organs. Agreed.
Yes, agreed.
The relative, for example, wife, brother, son, daughter, refused to the donation. Now the card is valid or not valid?
No, it's not valid.
Not valid.
Okay. Yeah, so we'll consider refusal and we will give them the dead body.
Yes, agreed. Agreed.
Yeah.
Respected. Yes.
Yeah, but we will try our best. By the way, they are not sitting with the family for once. They can sit with the family for multiple times to convince them. It's an argument. And sometimes they are using some tools like money and compensation, and also some insurance assurance for the son or for the relatives who's living with him or dependent on him, until they convince the family. Why they are doing that? They can help a lot of patients. For example, kidney patient or renal failure patient, heart transplant, corneal, bone marrow, lungs, any organs they can harvest from this patient. That's why they are trying to convince, but never they are forcing or taking it like he already agreed, so no need. This is the way how to, and by also by the sense. By sense, if you sit with the daughter or the son and talk with him like this in front of examiner, I guess they will mark you, right?
So
for example, if the surrogate,
yeah,
if the surrogate is crazy and he says, doctor, you told me you are keeping my father alive by keeping the ventilator on so that the organs will be perfused with oxygen and blood supply and medications. Why those vital organs are not helping my father to come alive?
Yeah, because his brain is gone.
Because his brain is dead.
Dead and gone, yes, or gone and dead, like this. Nothing will. Yeah, will put this brain again or regain the brain function.
Yeah.
This is the problem of the neuro tissue. It's not regenerate again. So whenever we are doing, it's dead, and nothing can regain the function of the brain. That's why he considered as clinically dead. As long as he's on the breathing machine, he is supported by this machine. Once we remove this machine, his heart will stop and it will be declared as clinically dead. Okay?
Yes,
Dr. Abdullah,
agreed.
yeah, yeah. Thank you, Dr. Dr. Abdullah, you want to add anything?
It's confusing actually. I don't understand why there is medical card because what is the donation card?
The card?
Yeah, what is the donation card?
It means that he has a card that he accepting to donate his organ.
Okay, why they
Will
put
directive
everyone
will.
for donation except opted out, and then there is a card. Like, what is I'm not
I think
understanding.
Okay.
I think the opted people which are below than 18 years and these things they couldn't donate their organs, I think. But for the normal people they have the donation.
Okay. Mm.
Okay, let's clarify this issue, Dr. Abdullah. You are in, I guess you are in Ireland, right? I remember like that, or where are you living? Or in Europe, I
Yeah.
mean? Okay.
You're Ireland.
So, yes, you can ask some of a consultant there or the policy in any hospital. And Dr. Sarah also in UK.
No, we don't
and
have this. Yeah. Okay.
I mean, you are in the theater itself, in the, so you can ask in the Europe, and I think the role in the whole Europe. So Dr. Sarah, she can also update us tomorrow. She can ask, but again, this is my
But
opinion.
I ask for myself for that.
She asked about herself more than this.
Because
Okay.
here in UK, if you die, the money won't go to the kids. You need to write a will to give the money to your kids. So I asked about this, and I asked about one of my friends did a will for that, and did a will. When I asked her about the organ donation, she told me if the family reject, so you don't need to write a will that you don't want to donate your organs, because it's many logic also, because here they are respecting every religious and every belief, so they shouldn't force some people to donate their organs. So this is, they will encouraging them, but they won't force them. That's why I'm saying this.
And so if okay, what about so it's the same as if there's advanced law directive or
Yes,
lasting or LBA?
yes, I think the
Okay.
organ donation card is as the advanced directive, that the patient left a will that he want to donate his organs.
Again,
Okay.
it makes sense to sit with the family and to convince them and to have consent for, and you can use the card as weapon. He already accepted that. Please just sit with your family and discuss this issue and update us about your approval. This is the way at the end how to get the consent. Okay, I will comment on Dr. Sarah. Please, can you share your scenario first? I will comment about a point you said, and Dr. Abdullah also said. So you can say clearly or frankly, his brain is dead. Okay, his brain is dead.
Yeah.
And once we remove the machines or support, his heart will stop and he will declare as clinically dead. So no need to say, for example, he's not with us anymore. This is also what I practice, Dr. Abdullah. I respect your opinion, but be clear and clear in the mentioning and explanation. His brain is not functioning, not working anymore, and we are labeled this as brain dead. We have been confirmed that by doing some tests, and the consultant also confirmed. It's not only one consultant, there are more than one consultant to confirm such dangerous diagnosis, because once you label as brain dead, he will be for organ donation. So it's sensitive diagnosis. That's why we are confirming it, but by many tools and more than one consultant. And I'm sorry to say, yes, he
Doctor,
is. Yes.
I think after this brain death examination, there is a apnea test, and after that, we have to subject the patient to cranial angiogram to know them. Supply.
This is medical judgment, but in the communication, they are not mentioning all these things. Just you can say this is a brain dead patient, and we confirm the tests for that.
He's dead.
Yes.
We confirmed
Don't.
with many reviews, with
Yeah,
more
with
than
many.
one consultant.
Just
Yeah.
Exactly.
want to ask a question because Dr. Abdullah is saying that the brain death has been confirmed from the beginning. No, I'm saying
No, I'm not saying that. I'm
no.
saying why
The
the
condition.
patient from the first day,
Yeah.
like the family will trigger this point. Like why you are speaking with me the third day now. So
Yes,
just how
think
to answer this question.
that's why I'm saying that the brain death has been announced now. That's why you are saying now
Yeah,
that the brain death, if the brain
but
has been announced, because to do the brain,
mm,
you need to have two consultants
okay,
to examine the patient and confirm the
okay,
brain death. So if the brain
yeah,
death has happened at the beginning, we won't leave the patient for 3 days and tell the parents that because that the brain death has been done
No,
from 3 days, but we're trying. No, if the brain death will happen, so if I'm telling the patient now, relative, that the brain, your father confirmed brain death, it means that the brain death happened now. That's why I'm confused about this.
no. I will tell you how Dr. Abdullah wants you to do. He
Yes.
wanted you to say, since he came, his condition was critical and his brain function was not okay. And for that, we did a lot of tests and a lot of image
Hmm.
and to be sure that his brain is not functioning. Once we get the diagnosis and the proof for what's called brain dead, we announce for that and we have to sit with you to explain the condition. So it's
mm,
he wants you to prepare the family from the start that when he came, he was in critical condition and his brain was damaged severely because of the accident. And you are like preparing the family for the next bad news, which is the brain dead. So it's not from the start it brain dead. No, it's taking time to confirm. Even between the tests, you have to give some time to give confirmatory test.
Yes.
You have to give a gap
Okay.
apart
yeah.
12 hours, for example.
Okay. Okay. So
Okay?
that's happened now. That's why I told him now.
Yeah, yeah, you're right. And Dr. Abdullah is right. He wants you to prepare the family.
Okay. Okay. Thank you.
Thank you. And Dr. Abdullah, your
Just give
scenario.
me 30 seconds. Yeah.
No problem. I will give you 1 minute. I will read the scenario and just prepare your points.
Okay.
Yeah, good. Dr. Noor said this. Dr. Noor, they put the card for encouraging people, not for enforcing the family. Yes, I agree for this point. They are putting the card just to encourage the family for this issue, to change the mind of cutting the
Mm,
organs from the body, because before they are refusing. Nowadays, by the way, after the social media talk about the organ donation, most of the culture and the community accepting this idea. We are getting here some acceptance and permissions from families in Gulf, as well as I guess in Europe. It's much than here. So the idea of the card is to give the encourage from the family and from the whole culture and community to be accepting this idea. They are helping a lot of
mm.
patients. Okay. Yeah. Thank you, Dr. Noor, for this comment.
Dr.
The why?
Bashir.
Yes.
Oh, sorry, interrupting you. Continue.
No. I will read the scenario.
Like
Go ahead.
how to continue, how to mention in the medical card as a weapon. You didn't. Can you explain that more? Like
No, I'm saying it for us.
like give me an example. Like how to tell it.
Yeah.
You're asking the patient. Yeah.
So I will tell you. Your father, for example, in this scenario, your
Yeah.
father always wished to help others in his life, and I guess he had a card that he can donate his organs whenever he's not with us or he's dead. That's why we are here to
Mm,
discuss about organ donation. What you mean, doctor? Yeah, as Dr. Sar said, he could be more, no, I will not say happy, but he will be more helpful if he donate his organ to such people who's suffering in their life, to have a good quality of life whenever they have this organ from any dead person, like in your father condition. Okay.
But and also, I think it's better not to say his organs are warm to give it. This is, I think the patient will feel more bad. But how will say that this is the suitable time to ask you about that? Because the patient might, as Dr. Abdullah told me, why you are asking me now? You can postpone it. So how we'll make it? This is a suitable time, or this is we want to discuss it with you in this time because
Yes, once we have the diagnosis, we have to think about it. Why? Because whenever he's on these machines, even with this support and with this medication, sometimes his heart stopped, and we cannot do this organ donation in the coming couples of hours. Sometimes even the patient has brain dead, and you didn't harvest his organs, the heart will stop even with the maximum support because no more control from the I mean higher centers, which is the brain stem
no,
and
I'm asking about how
the timing.
yes, how we'll tell the patient if the relative is saying, as Dr. Abdullah, why you are saying now about organ donation, you can postpone it. You are giving me a lot of things now, so I couldn't.
Yes, I said the same idea, Dr. Sarah. You have to say whenever the brain did in medicine, it's related and linked to organ donation.
Okay.
So
This is
the both condition are like linked together. Whenever we have brain dead person, we are always candidate or they are potential for donation since
uh,
we have the diagnosis. This is and by the way, it's in the practice, in the real practice. Whenever we confirm brain dead person in ICU, we always call the SCOT team, which is organ donation team. Even before confirming this, whenever the patient comes in coma state and his brain is not functioning at all, severe head injury, we suspect brain death, you can contact this team and you can aggravate the steps of organ donation.
okay.
It's related, by the way. Whenever you have condition with brain hemorrhage or brain dead, you have to talk about this thing. Even it's not written in the scenario, but they are mentioning it in the scenario nowadays.
Okay.
Okay, especially young patient. Okay, the scenario: wife, Mrs. Vicky Davy, a patient under your care on the stroke ward, has requested to see you. The patient, Thomas Davy, 52 years, was admitted 8 days ago following a CVA. CT showed a large MCA territory infarct. He has made little or no improvement since it happened. He has a dense right hemiplegia with a homonymous hemianopia and a severe dysphagia. He has poor sitting balance and has an NGT tube in place, medication aspirin, atorvastatin, paracetamol. Discipline for Mrs. Vicky, her husband's condition, and address her concern. If you're ready, we can start, Dr. Abdullah.
Mm, okay. Yeah.
Okay,
Hello,
here you
I'm
go.
Dr. Abdullah. Yeah, let's start. Hello, I'm Dr. Abdullah. Can I start now?
Yes, yeah.
Okay. I'm Dr. Abdullah. I'm another one of the medical doctors in the stroke ward. Am I speaking with Mrs. Mrs. Vicky David,
Yes.
um, the wife of Mr. Thomas?
Yes, doctor. I am.
I'm here to discuss with you about Mr. Thomas as per your request. Um, and I I believe that you must be concerned. Can you tell me what do you know about what you have been told so far about his medical condition?
Yes, I know that Davis has a stroke last week, and he has been admitted in the hospital. And the doctor told me that the stroke, he's having a big stroke that is affecting his brain. So this is what I know till now.
Okay, I appreciate your information and telling me for that. So yes, he was admitted with since 8 days ago. Um, and he was like having weakness in his arm and movement, and in his ability to swallow, and ability to see things, and it quite affected him. And I'm sorry to tell you that we did investigation and appeared that his stroke is large. There is a large clot in affecting his ability of the brain to function.
Okay, but doctor, I'm very confused because my husband has been admitted. They removed him 4 times, and lastly now we are in the stroke unit. I know that this is a good place for him to stay, but one of the nurses was told me, many nurses told me several update me regarding my husband and saying some of them say he's not in good condition, but one of them told me that he can recover and he can be well. So I don't know what's happening, and if he can be well. No, I couldn't see any doctor for the brain coming to see him. I see there is some neglect here.
Okay, sorry to tell you that. Sorry if you feel such thing.
There is a lot of information given to me, so I want the update about my husband and what we can help him to proceed forward.
Okay. So I appreciate this is a very good question actually, and so as you know, what happens in stroke, a dead tissue forms in the brain, and because of the clot effect, preventing the blood supply to many of the muscles of the swallowing and affecting the vision, and also preventing his hands and hand and foot of the right side of the leg to be able to move. Well, he has weakness which is unable to move his right side totally. In that case, we first give medications, and we started giving aspirin in a high dose as per the local and international guidelines. And we start give medication to improve, to optimize the his condition. But in his case, I'm sorry to tell you, so these medications will not help him to recover back because of the large area that has been affected. It's only prevent him from prevent him from getting further clots in the future.
So,
yeah.
So why one of the nurses told me that he will have a full recovery and it will be possible?
So yes, it's so initially, if there is an initial time period, if there is an early at the early time of within 4.5 hours, if in that area, only in that time window, that's the only time of possible recovery. If there is, usually in some cases, and based on a thorough assessment, we can give something to dissolve a clot. But in your husband case, I'm really sorry to tell you that it's not the case, because the clot is big enough, and in some cases, if we give such medication, and also there is a risk of bleeding, and also because the dead tissue already formed, after these days since it started.
Okay, but I can see that I couldn't see any doctor seeing him, and only the physiotherapist can
Mm,
see him only.
mm,
So I'm thinking
mm,
this NHS, there's some neglect. I want, and I have private insurance, health insurance.
mm,
So I would like to transfer him to the private hospital. He might have here, and
Well,
the doctor will see him more frequently and give me second opinion about that. Is that
I appreciate your concern. Okay. I appreciate your concern. I let let me tell you that we are in these cases usually I wouldn't recommend that you start transferring because you will he will get we know him now, and if he is getting a change in the hospital, and there is a lot of procedures to be done, and that and the doctors who might meet him there will difficulty in um, he is not in a good status actually, and the transfer is not suitable for him. Can I discuss with you about what we need to do for him now?
okay? So you think
He,
it's difficult that we can transfer him to other hospital and take all copy
we,
of the test and the scan so they can
we,
have.
we, we can do that, but the problem is that it's difficult for him because he is at risk.
2 minutes left.
He is at risk of getting a problem of getting infection in the lungs because he is in a we put a tube in connecting for his medications and for swallowing because his weak muscles in the mouth, he is at risk of what we call aspiration, and that's very life-threatening. In the transfer, it's very difficult in this status. I would wait for him to be in a better. I wouldn't advise you to transfer at the moment because it will be bad on him. The second thing we are doing is keeping him mobility, and he is not having, especially in his case, he's at risk of forming sores. So he needs continuous shifting. He needs continuous nursing care, and we are providing him painkillers, and we are providing him support through a speech and language therapist, which he needs rehabilitation care, which is the form of that they act in the best possible services, providing mobility through physical therapy, and they move his arms continuously in a good, safe way, and legs, and also try to provide him exercise with the speech and swallow. And that's not an easy process initially. I hope this makes
But why you ask
sensible to you.
the private hospital won't do for him all these care? They can give him all this.
Okay. If that's your concern, but I'm telling, I mean, I would I can arrange for you, but I mean, I want him to be in at least initial time of rehabilitation with us, so that you can transfer him in a better status. Now it is critical for him, and it's not good for him to be transferred in this status initially, especially in this time period.
Okay,
Okay.
this time is up. Yes.
Okay.
Okay.
You
So
can comment it now, Dr. Sarah, please.
you did well, but I think at the beginning, when you talk about the window period and 6 hours, the patient now is 8 days. So the issues now that the patient is confirmed that he has a massive stroke, and he started to have the hemianopia and hemiplegia and dysphagia. So what we will do now, we will it will take, you will tell her his condition, he won't get back to the normally. Because when you ask me, I will tell him that he was completely also dependent. In this station, you talked a lot. You didn't give me time to talk, because I think you should make it two ways. Talk for 1 minute or 2 minutes, and then wait to the patient to talk. You took maybe 4 minutes to talk, and I didn't say anything. So I think it's better to make it two way. This is from the beginning. So I will say so you will explain for you. I will tell you that he was independent before entering the hospital. So he will say he won't get back to this seat because the stroke is massive. But we'll try our best that we will, physiotherapist will help him. It will take time, and we couldn't predict what disability, which part in his body won't had full recovery. It's too early to predict it now. So, and when I'm asking you about the private hospital, so you said that the private hospital will not do for him. You won't say, don't say about bad things about the other care. No. So what you should be in the middle. So you can
No, I
say that
didn't say bad things to them
no,
at
you
all.
as a patient need to be we do bad
No, I mean
pose
it's for
and
the
the
patient.
aspiration. The patient already
Um,
gastric tube, so he won't aspirate. It's written scenario that there is a gastric tube in place, so there is less chance for aspiration for this patient. So I think what you will be in the middle to say yes, private hospital is very good for elective operation, but giving your husband actually unwell right now. So I'm not quite sure private hospital will be the most appropriate place for him or no. You said it in other way. You did it right by saying yes, his condition is not stable now, and then if she insists, we can help you to facilitate that. But at the moment, I didn't recommend this. I don't think they won't have other opinion as our opinion. So you can, if you insist to do that, we can help you. So you will be in the middle, not with or against. You will respect her what she's saying. So yes, private hospital, it can be a good option for the elective, but your husband is not, I can see that he's still is acutely unwell. So we can wait. But if you want that, I will discuss it with the consultant and we can facilitate that. Okay, if she insists. So you make it, you will be in the middle, not against or with. You will give her all the choice and keep her, she will think about it.
but did you say operation? You didn't say operation while in the
No,
scenario.
no. I'm saying
Like you were not telling me
no,
in the
no.
private.
You will say that the private hospital is very good for elective operation when one had an
What operation?
elective surgery. If someone, you will explain for her that the private hospital can be a good option.
You mean
Okay.
gastrostomy tube?
If surgery, you don't need to wait for the NHS on the waiting time. If you want to do an operation and it's elective in the NHS this week, it's meaning that you are trying to explain
Mm.
the private hospital are good if you want to do an operation now, which is not urgent operation. You can do it now.
Oh,
This is
like in general, like you are explaining in general. Usually the
yes,
private hospital are good in elective procedures and elective
so
surgeries.
you can say that. But giving your husband
Okay.
is acutely unwell, so I'm saying
Yes,
not right decision. So, but if you happy with that and you want that, we can help you to facilitate this. So you will give her the option. You didn't object. Okay, and also you will tell her that well, is a stroke is massive, but we will try as much as we can with the physiotherapist to help him to move, and the soul team also will help him with the swallowing. You talk about the rehabilitation and you talk about some of them, so you will reassure her regard that it will take time, but and also at the same time it's unpredictable which what recovery he will have it at the end. And you can see and also in the scenario it's written the medication that the patient is taking, so you can say that we are giving him this aspirin, this atorvastatin and paracetamol. Anything written in the scenario you should say it to the patient. So this is
I said aspirin as of,
yes.
in the
So
beginning.
you told her all the medication. I didn't hear all the medication because there is medication list written in the scenario. So you will explain for her what we are doing. She doesn't know, and she's saying that she's
Yeah.
only one doctor seeing him, and the conflict of the nurses and for the conflict of ideas.
Yeah.
I'm really sorry about happening. And
What
this misunderstanding.
what about, yeah,
Yeah,
what about this concern about
yeah.
there is no doctors coming?
Yes, so you will tell her usually our team are following him, and let me check it, and then I will update you. The neurologist, we have your for your husband. We have a group of teams that we make a plan for him, and we are doing meetings, so they will visit him and regularly following him up. Because she might not present all the time to know that the doctor, but she was saying to you, the nurse is telling me that why is this conflict? So you said, I'm really sorry about this conflict of idea and this misunderstanding, but let me discuss it with them and see why they told you these things. But usually we are keeping the patient updating by us. So I will double check and come back to you, and you will only say sorry about this conflict that happened, because one of the nurse told her that your husband will have a complete recovery, and this is not the truth. So you'll try to explain for her. So I'm not quite sure what happened and who told you. So let me revisit and check it, double check it with the nurse and come back to you. So this is one of the concerns that you're saying, the conflict of idea and conflict of opinion, and you will tell her. So from now on, I will keep you updated on daily basis regarding your husband condition, and if you have any other concerns, you can tell us at any time. So I think that the patient, no one is updating her regarding her husband. So you will explain for her the situation and explain for her that he won't recover again, and explain for her the private hospital, and the private hospital will give her all the care. But I think that his condition is critical now, so it's better to stabilize him, as you said. Okay, this
Yeah,
is
but doctor, just like I didn't. Did you hear me say something bad about the private hospital? Maybe I say it in a way I didn't like. That's a problem. I
no.
don't.
You said your husband need to be we need to change him from side to side regarding the bed sores. So when you are saying, it means that the private hospital won't do that.
Yeah, yeah.
It's
Okay.
it I understand it like this, that the
Okay.
Yeah.
Okay. Okay.
hospital
Okay.
won't do these things. So
Okay.
Yes.
and you are
Okay.
doing only these things, so it means this is some discrimination. So we need to be
Mm,
middle, not with this one or this side in NHS, or not say the NHS is bad or the private is bad. So we need to be in the middle. So we will talk about her husband in general. But what I understand, when you're saying that your husband he might be aspirated, your
mm.
husband may take
Yeah.
bed. So
Yeah.
I
Yeah. Yeah.
that these things won't be protected from him from the private care. That's why
Mm.
I ask you in between, so they can do it for him. And then I'm telling you now in the discussion, to in good communication, it's two-way, and to be in the middle, not be with, not be against. So that's why this is
And
my
here's the difficulty. Yeah.
yes, this
Thank
is
you so much.
Yeah, thank you, Dr. Sarah and Dr. Abdullah. Regarding this point, I will start from this point. Yes, don't assume your hospital is good and the other might not give the care we are offering here.
yeah,
This is also what I understood, that you are, yes, you are caring much enough than the other hospital. Don't show her this message or show her this like you are caring. No, even you are caring more than the other hospital. She can have the right to take him, even to get his father to a clinic, or even some I mean careless hospital. Even she will take him home. You can advise her, but you will not say, no, we are offering here something which is not in the others. You can say, according to for the transportation, I mean, he is not suitable now to be transferred. Whenever his condition is suitable, you can take your father anyway. So this is the way. But to say, no, we are giving him the care that he will not get it from other hospital. You don't know what is the other hospital. Maybe much better, maybe much worse. But at the end, this is her wish, and the family wish to get the father or to take the father if the other hospital accepted. Okay, this is regarding this point. So try to be, as Dr. Sarah said, neutral, or don't talk about other hospital. Talk about the transportation itself. I can't, or it's not suitable now to let your father go. Okay, Dr. Abdullah, this is the way how to address this point specifically. Don't talk about
Mhm.
your hospital or other hospital. No, it's a matter of his suitability to go. This is for
Yeah.
this point. Yeah, for the other point, yeah, I want to say about the jargon. In the previous scenario, Dr. Sarah, you said resuscitation many times. So the best way to say, you can say we did initial measurement or some measures at the beginning, but it didn't help him.
Can say to try to save his life, maybe.
Yeah, so the measures to save his life, but
Yes.
never say resuscitation. Or you can say resuscitation and you can
Then
explain that because he asked you also. Good thing Dr. Abdullah ask you what you mean by resuscitation. He's like asking you to explain it. And I guess Dr. Abdullah was a good surrogate in the previous scenario. He gave you hard time.
I will cry. I
No
will.
problem. Yeah, it's better to cry here. You
What
face.
do you mean by his dying? What is mean by his
Yes, it's good. Wallahi, I swear. It's good to cry in the practice rather than crying in the exam.
Yes.
And you saw, yeah, you know the drawbacks of stressful
Yes.
situation in the exam.
Mm.
Always you are forgetting things, but whenever you do it in a stressful and hard practice with hard surrogate like Dr. Abdullah did,
Yes.
it's the best way. You will learn from it and you will practice it direct in the exam. So
Yes.
yeah, thank you both of you, Dr. Abdullah and Dr. Sarah. I guess
Thank
yeah,
you, Bassem.
yeah. Thank you
Thank
so
you, Dr.
much.
Sarah. Thank
Any question from Dr. Sarah, Dr. Abdullah, or others?
No.
Thank you, Dr. Sarah. Any
Awesome.
questions? Yes.
But in this scenario, can we discuss advanced directive issues and lasting power of attorney?
Actually, yes. In this scenario, when his condition is not improving and he's in coma, you can touch it and you can also check the lasting power of attorney specifically. Why? Because this patient condition might not get improved, and you might get the lasting power of attorney as document in his file. So who's taking care of him? Yes, I am the one. I am the daughter. I am the next of kin. You are the one nominated to take decision on behalf of him. This is one of the legal issue. Who will decide for transportation? Now the patient is lost capacity, right?
Yes.
His capacity is lost. So
you.
who will take
I was,
decision? Ah,
we were
yes.
not sure, like, was there any mention? Stroke does
Yes.
not equal loss of capacity. Like,
Yes.
they didn't mention
I
GCS.
Okay, let's hear
that
from Dr. Sarah. Yes.
this scenario is on past test and communication. So it was like this. They didn't discuss. So it was. I saw the both acting. So they were discussing only the private hospital and the conflict, and the
Okay.
take time.
They didn't mention about lasting power of attorney.
No, they didn't mention this.
And his capacity was preserved, so the patient was,
No, they
or
didn't say anything
no,
about capacity. They say
they
that
didn't.
time, but we are not predicting how much will be dependent after having this stroke.
For me, if this scenario came, I will ask regarding the point of transportation, why she want to take her father out. So I can ask her if he nominated you to take a decision on behalf of him, because I have to get the approval either from the patient if he's okay and preserved capacity for him. If not, she will be the one, and I will proceed for the transportation whenever she is the one nominated by her father. This is my opinion. Also, don't take it as a rule.
I also agree with you. It should be. It should be.
Yes, yeah, because this transportation is a decision now, and who will take and who will decide this? I guess either the father if he's preserved the capacity. If not, you can ask in quick view, are you the one next of kin? Did he nominate you to take decision on behalf of him? That's it. But for the for the advanced directive, I don't think he might live longer.
Yes.
So yeah, so it's not the matter of he will be dying soon. No, it's the matter for decision, how to get decisions or something related for to the father. How we can get it from the lasting power of attorney, which is the son or the daughter.
Yes. Yes.
Okay, thank you, Dr. Azhar, for the
Dr.
nice
Bassem,
question. Yes.
regarding this transfer, when the a surrogate is asking, I want to shift my father to other hospital, we can
Mhm.
say that the protocols of treatment will be the same wherever you will take, and
Yes,
the protocols will not be changed. Number one. Number, if the still he will not agree, then can we have a meeting with my consultant so
yes,
that he may be able to
yes,
explain you in a better, in a good way. I
yes,
think we should, and then at the end, if still he will say, okay, no problem, any advanced directive wishes and lasting power of attorney, and the time will finish. I think.
yes, yes. I think yes. This was this condition. We can revisit this again, and we can discuss it with the consultant. And if you will still insist, we can help you to facilitate that. But we will tell her that the care is the same care. They won't have this other opinion than us, and it will be the same care.
But again, my also this is my opinion. You have to know why she want to take her father out.
But she's
If she
saying
said,
not
yeah,
by doctor
Yes, yes. Very
NHS
good question.
the poor. She was saying that the NHS was the poor place, and I think there's some neglect. I say it in the scenario.
okay, if she mentioned that or assume there is neglect in your hospital, you have to defend your hospital first, and you can tell her at the end this is your decision. But we can't do it right now. We have to check the suitability for your father first before leaving him or letting you take him.
Yes,
A- And we can arrange a meeting with consultant to finalize this issue.
yes,
Yeah, this is a good way to approach it.
yes, yes,
Okay. Always, whenever you have like request to leave the hospital or to not to receive the advice or not to receive the management, address it. Why you want that? Why you want to take your father? Is something related? As he said in the scenario, your doctor is not passing or not doing round on my father. You have to also clarify this issue. Don't leave it. If you skipped it, you will be minus. Why? Because this is against the hospital. Why the hospital is not taking care and doing care for your father? So you have to say, I'm so sorry if you feel that or you see like this or you misunderstand this. However, I will go back to the office or to the department to see what's exactly ongoing, and after that, I will address the concern with you and update you about this result. Okay,
yes,
so you don't skip it. Try to analyze and to address this issue. If he understood, he might also accept to be in the same hospital. If you told him no, it's not accepted, and this is not our usual habit. We are always doing care for our patient. The doctors always with the caring of the patient, and I'm so sorry to feel that. And let me confirm this, and I will be back to you.
yes,
She might be accepted that you can leave her father at hospital.
mm,
But again, if she insists, no, I don't want, I want to take, he's or she is having the right to take her father by any way.
yes.
Okay. Thank you, Dr. Sarah and Dr. Abdullah and Dr. Azhar also for this question. Any other question? Okay, Dr. Ehda asking, can you confirm to us aim in this case? Explain the condition as in scenario, discussing the causes of no improvement. Yeah, it's an explanation for any stroke. As you know, Dr. Ehda, you can say it's a blood channel supplying the brain and it being blocked or occluded by a clot. Then the brain function lost in this area. And the effect will be, as you see in your father, like weakness or sensation affection or dysarthria or whatever the presentation is. The cause of no improvement because the brain tissue is not being back to normal easily. Once it's damaged, it's not regenerated again. That's why your father might live longer with this condition. And always there is challenging for rehabilitation and let organ or let the arms to work again by some help from the social team or the physiotherapist team. Simply to do that. This is the explanation and the drawback of the stroke. Is it clear, Dr. Hida?
Doctor, do we have to ask for a consultant opinion also by the second visit? Because she is
Or
angry with the doctors that they are not visiting their father.
yeah, you can say that. You can also update your consultant with this. For him, I mean, you can tell him, yes, we will update our consultant about this if you feel that. I'm so sorry if you feel like that. And we always do care for our patient regularly. But let me confirm what happened, and I will update also my consultant. But let the consultant let the next step, if he is or she is insisting for complaint, for example, yeah, I will let you sit with my consultant to explain to you that things happen here, and also to convince you if you are agree to sit with him. But don't put it at the first option or first choice. Why? Because the consultant will think that you are not able to fix all problem from the first time. Whenever you have a discussion and argument with the family or the patient, just try to convince it or to convince him. Take your time. If he agreed, okay. If not, the next step or even the last step, okay, I will let you sit with my consultant. He has a much better way to convince you to address your concern. If you agree, let me arrange the meeting as soon as possible. That's it.
Okay, doctor.
Okay.
Here, there are two things: miscommunication by the staff nurse and a misconception by the patient relative that the hospital is not good. Can we use these two words as a normal words to the patient, or it will be under jargon? Miscommunication and
No,
misconception.
it's not jargon. No, it's not jargon. And even you can ask him to say it. You can tell him what happened. What are you okay? Let me know what's wrong with you, like that. Then he will explain to you. I face this problem. I didn't see a doctor reviewing my father. I see a nurse not taking care of my father. So let him say it. Don't ask him by your. If he didn't mention it, you can tell him. I read that you have a problem with the nursing issue. You have a problem with our doctors, like that. Okay, and he will explain to you more. So it's as Dr. Sarah said, it's a conversation way. You ask and he will answer, or you let him talk and you can address it. Okay, but don't take history. Take care if not taking history. If you take history, it will be against you.
Okay, doctor. Thank you.
Okay, most welcome. Okay, thank you, Dr. Ihda. Any other question before ending the session? Thank you, Dr. Abdullah, Dr. Sarah, Dr. Azhar. All of the colleagues attended the session. I know it's so long, as we have some of the participants volunteers for long and communication. So I did this session today to help others. But the rule is to make one communication and one communication, or I mean two communication, or two long clinical. But once we have some volunteers, we can do 4 cases, just to do the practice more and more and to help others. Thank you, Dr. Maha. Dr. Ihda, we'll see you tomorrow, inshallah, if no more questions. See you with another day tomorrow. Good luck and good night. Assalamu alaikum wa rahmatullahi wa barakatuh.